Evet doktor, başlayabilirsiniz.
Tamam, teşekkür edirəm dəvətiniz
Bir dəqiqə. Təxminən. Və suallar bunlar var. Spikerlərə qulaqçıqlar. Tərcümə kimi eləyəcəklər?
Onlar necə işləyəcəklər? Нет, ну конечно, да. Başlaya bilərik Teymur müəllim?
Bəli, buyurun doktor.
Təşəkkür edirəm bu möhtəşəm tədbirdə, möhtəşəm konfransda məni də moderator kimi dəvət elədiyiniz üçün çox sağ olun.
Doktor, zəhmət olmasa yaxın tutun.
Yaxına yoxsa uzağa?
İçinə yaxın.
Aha, tamam. Ümidvaram ki, qonaqlarımız çox dəyərli mühazirələri ilə hamımızı maraqlandıra bildilər.
Please check it if you can hear me. Okay. Thanks all of you. Our lectors is here for more than 2 days. They eat our meals. They visit our country, our city, and I hope that we'll do so good questions for them. First question is given by the Bakhtiar Aliyev. Do we do 3D splints or do we do 3D prints digitally or do it manually? If we do 3D, what material we should use? O Azərbaycan dilindən hə. Next question given by the Dr. Muharrem Mammadov. I won't say that your question is so big, Muharrem Doctor. You have some identifications. This question is given to the Cinzia. Firstly, I want to thank all of organizers. We know that mandibular TMG is the synovial joint. If we do reposition, always we make a mandibular position under the disc, and we do like this. We do like this position. What do you prefer? Do you do like this, or you have any other choices? and about your experiences on the MRI results. Okay, can I explain to you?
Condyle displacement, of course, and sometimes also, and it is something disc displacement related to the fossa, temporal bone, and condyle. When we're doing the repositioning of the mandible to reduce the disc, to treat the patient with the disc reduction, we change the position condyle to the discus to reduce the reduction. But the position of the discus to the fossa and temporal doesn't change. Could it be influenced treatment and patient situation or düz tərcümə edirəm, mənim doktor. Huh? Or treatment protocols or patient muscle palpation or treatment some situation. Did you get the question? Can I translate?
I'm not sure I understood. Is on? Yes, it's on.
Yes.
I apologize because I'm not sure I understood the question, at least not entirely. I will reply as far as I understood,
Yeah.
and as far as I can do, not being a clinician. So what we know is that reposition of the disc is possible, but not in all cases. So there are cases in which especially when the disc is not reducible, that treatment can be applied, but not with the goal to reposition the disc. So in the more advanced cases, this is not going to be possible. Still, the position of the condyle with respect to the anterior slope can be improved. Now, I would like one of the clinicians, Daniele or Anastasia, to take this question and maybe elaborate more on it.
Can I just clarify the question,
Or
just a
Ian
little bit?
as well, of course.
Sometimes we can see on the CBCT that the position of the condyle quite okay. It's not retruded, it's not backward, but we have this dislocation with reduction. It means that could be the dislocation both of these anatomical structures, discus and the condyle. Yeah. But we're in the treatment protocols, we are trying to reposition condyle. We couldn't do anything with the discus, of course. We're trying to treat patient with reducing the disc by moving the condyle forward, repositioning. But if the reason is the dislocation of disc could be anteriorly, not just position of the condyle posteriorly, could it be influenced treatment protocols or some muscle palpation, patient complainings and other things? Because actually condyle in the right position is the
Ian
correct
would
position.
like to take the question, or Ian?
Okay,
Ian would like to take the question.
Okay.
Thank you. I think we have to think of the fact that the disc can be three-dimensionally out of position laterally, medially, and some combination. And in many cases, the disc is not even, there's no possibility to actually reduce it. So the treatment has to begin with really accurate diagnosis through our muscle palpation, occlusal analysis, CBCT, and MRI. And we take all of that information together to actually create a therapeutic position. We use the condylography to create the therapeutic position three-dimensionally. It isn't just anterior, it can be sagittally also in the y-axis, which is left-right. And once we come up with a defined new therapeutic position for the condyles, we look at the occlusion to see what we are going to create there. And then we use muscle palpation, minimum of 8 muscles to compare with test bites, as I showed in my lecture, to actually see the effect on the muscles. The muscles are basically the influencers. They're the ones that react first to both dysfunction and the ones that react first to a better condylar position. In some cases, we're not trying to reduce the disc, as Cinzia said. We're trying to create maybe joint space, maybe a more anterior position just to reduce compression of the bilaminar zone. But all of those factors have to be considered. Therefore, it goes back to having as much information about the entire presenting situation as we can have. I hope that helps.
I will speak English so that there is no confusion in translation. So think about the disc, the lower part of the disc is like an actual functional fossa. Your condyle is supposed to touch and be in contact not with the fossa but with the lower part of the disc, okay? So for us, the right position of the disc is preferable. We like it. So we basically judge how the condyle is positioned to the disc, not how it's positioned to the fossa. But the position three-dimensional of the condyle to all other structures is also important. We cannot, let's say, reposition 5 millimeters forward, trying to catch the disc. There is a certain limit. And in a population, there is a variation. Somebody has a condyle in this position, somebody has 1 millimeter more forward, and so on. So we should just put ourselves a limit, and if our diagnostic tells that we can reach a therapeutic goal staying in this limit, we should go for it. If we need to go above that limit, we should maybe say, okay, disc is not in place, let's go to plan B and just secure the joint with a different, protection.
Yes, I would like to add just small details. First of all, the diagnosis must be always confluent. So we need, must be complete, okay? So as Ian said, we need MRI, we need CBCT, we need condylography, because only one exam is not enough to understand everything. And we start always from the clinical examination. This is the first aspect. And second, think about also, for example, the variation of the sagittal condylar inclination. If you do a mandibular repositioning in a shallow eminence, is a story, but if you do it in a very steep eminence, is another story. So individual variation are always important, and also the limitation, as Anastasia said. We cannot reposition the mandible as forward as we want or we would like. Okay. There are limitations.
2-3 millimeters, Cinzia showed you in the presentation. So
the guidelines. The guidelines. Cinzia said the guidelines.
Yes, no, I didn't set the guidelines, the clinicians, yes, I explained, but I really didn't report millimeters, so if they are confused about the millimeters, it's because no one spoke about millimeters. To their defense, they cannot know that, not yet.
Təşəkkür edirəm məruzəçilərə verdikləri cavaba görə. Növbəti sual Dr. Toğrul Əliyev tərəfindən xanım Anastasiya Saltıkovayadır. Anterior disk desplasmanında cərrahi antroskopik disk repozisyonu haqqında nə düşünürsünüz? Anterior
disk display during anterior disk displacement, how do you think surgical procedures for disc replacements?
Let's say that in our experience, surgical procedures are the last, because our joints are very small and any invasive treatment can cause more problems. If I don't remember in a bad way, Ian had the case where the patient need more than one surgical treatment in the joint, and at the end was a disaster. Not because the surgeons were bad, but because the surgical treatment of the joint is really very difficult and not successful in the long term. Sometimes there is a need. I had a patient with osteoma of the condyle, and there was no way to treat him without any surgical treatment. But then we did also the orthodontic treatment and the prostate reconstruction, and since now is fine. But
yeah, I also think that actually probably, I don't know, 20% of us also have this dislocation. Somebody? Are you okay? So if you have normal function, normal mouth opening, if you manage with other treatments, get a nice function, no pain, I would not personally go for the surgical, but if you're a surgeon, you know that they can really put the disc back, fix it, and without creating any adhesions, any scar tissue that will cause another problems, then okay. But I think it's not necessary to go for the surgery for such a problem. You can live with this. You can make a function very nice, actually.
An interesting point is this question came from the oromaxillofacial surgeon.
Növbəti sualımız doktor Aliyeva Günel xanım tərəfindən, yenə də xanım Anastasiya Saltıkovayadır. Splintlər nə qədər qalır və dişlərə nə vaxt onlay qoyulur?
Onlays to the teeth.
How long the patient wears the splint, it depends on the diagnosis. If it's a small partial disc dislocation, I would say you can move to the overlays very fast. If it's a complete disc dislocation, you want to wait and make sure that the click is not coming back. Let's say I usually wait months or two and then I just fix overlays. If you have a more complicated problem like disc dislocation without reduction, then we work with the splint in several steps, and it can take up to 3 months, maybe sometimes, but I don't like to stay on the splint long because I'm an orthodontist. I don't jump immediately. I will continue my treatment, and I know that motivation of the patient goes down, and probably after 6 months they're gonna stop wearing splint and the symptoms come back. So I try to limit myself to 3-4 months and then continue with orthodontics on overlays. Overlays are doing the same job as splint, but I can start with the next step.
Ну, здесь почти что похожий вопрос. Значит, в работе с окклюзией мы используем репозиционную капу. Скажите, пожалуйста, надо ли использовать эту капу во время пищи? Если да, то мешают ли пациенту четкие бугры постериоров, которые во время переживания пищи они блокируют?
The controlled mandibular repositioning, according Dr. Landry, is done in the way that the splint should be wear by the patient during chewing. But the splint is a special one. It's not the standard splint that we use. A myopathic splint is not used during mastication. Just when the patient feels that there is a problem in the muscles. Okay, so. And for a few months. So each splint has a clear purpose and a clear indication and the time that it should be wear.
Sual Ramiz bəydəndir, estetik diş. Tərcüməçilər tərcümə edirlər. Yəqin ki, Ramiz bəy deyir ki, okkluziyanı nizamlamaq üçün, okkluziyanı bərpa etmək üçün hansı overlaylərə üstünlük vermək, hansı materiala daha çox üstünlük verərdilər bizim məruzəçilər, kompozit restavrasiyalara yoxsa seramik restavrasiyalara? Sualım yan və Daniele'dir. No, we didn't get the translation. Tərcüməçiləri eşitmir. Yunus bəy. Okay, I will explain that.
No. Just repeat.
For more, when you reconstruct and rebuild the occlusion, the composite materials or ceramic, porcelain materials?
For the final reconstruction, you mean?
Yeah, sure.
The material for the final reconstruction should be a stable material. If the composite is not stable forever, so I prefer ceramic materials, basically, for the final reconstruction. Also for the aesthetic is better. Even if the new composite are improving a lot compared to the past, but anyway, I prefer to have hard materials.
What do you think about the combination of the material, guidance and front porcelain and function, posterior teeth, a composite?
Posterior teeth are the teeth that should support. So I prefer to have strong material also in the posterior area. As soon as the dental technician is able to design a nice occlusion in a perfect way, I want to have strong material in the posterior teeth also.
How about you, Jan? What do you answer?
I totally agree with Daniele. My general materials for final reconstruction, all 7s I do in gold. 6s I will do in ceramic, either porcelain fused to metal or usually Emax. And 5 to 5, I generally use Emax. Occasionally, if it's a full reconstruction, I will also use zirconia, depending on the patient. But the problem we would run into with composite is that we're using our occlusion to stabilize a joint, and we cannot afford to have any wear going forward on the teeth, because that will cause a reciprocal problem within the joint itself. So we need to use occlusion to stabilize, therefore, the strongest materials we have.
I would like to get also opinion of the Joanna as a dental technician, and her answer would be.
Okay, in my opinion, also the Emax is the best material, the disilicate, because it's a closer material to our enamel, natural enamel, and when we reconstruct the natural way occlusion, we want to work it the same way. So the 6 is support the height of the occlusion. Maybe from financial reason, if you want to make cost lower, you can use composite maybe on 5, on 4 maybe, but the 6, 3 and front should be in ceramic, and the best for me ceramic is the
siz sual müzakirə edirsiniz, yoxsa mövzu başqadır? Sual müzakirə. Thank you very much for your answer.
Davam eləyək. Növbəti sualımız yenə də Dr. Məhərrəm Məmmədov tərəfindən verilib.
Other question is given by the Dr. Məhərrəm Məmmədov. The verticalization, during the verticalization, did you consider the heads?
Diskin oynak başı üzərindən repozisiyası zamanı diskin remodelingi necə edirsiniz? Yəqin ki, sual müxtəlif mühazirəçilərə, lektorlara verilir. Tamam, təkrarlayayım mı?
Okay. During verticalization in occlusion, the head's posterior rotation you consider, and distraction is doing directly or step by step. Okay, that's okay. The question is okay for you? Okay.
Here, verticalization. Yes. Okay, the verticalization, since we have a true hinge axis in our articulator, we always do in one step. We're not afraid that something happens with the condyle. We are sure that the condyle position correct, and this will not influence. If we talk about destruction in the joint, means increasing the space inside the joint, then you have to go step by step. So if you will do a big destruction, the patient probably will not, the mandible will not rotate successfully forward, and you will not create. And also you can create a muscle spasm. So the rule is like this: we go with the small steps. Usually I take 1 millimeter, maybe in some cases 0.5 millimeter, and in a very loose ligaments, very relaxed muscles, sometimes a little bigger, like 1.5, but usually 1 millimeter is the standard. 1 millimeter, then you wait. The patient comes, if you see that all teeth are contacting with the splint, you can add another one and leave the patient go home and wait until the mandible is rotating. Okay?
Yes, it's my experience also. I agree.
Используете ли вы тенс-терапию в работе? Да. Если да, помогает ли это ускорить адаптацию нижней челюсти пациента?
Кто задал этот вопрос? Поднимите руку. Of course, okay, TENS therapy, and if we use it on why, exactly for that cases that we just discussed, when you have to do the destruction in the joint, in my opinion, TENS is very helpful, because if you relax the muscles, this rotation destruction is going easier. So this is the only indication for me personally when I use TENS, to really speed up this process of destruction and disc repositioning. So nothing else. I do a bigger step, I use TENS, I give a patient a splint, and the mandible is rotating much easier. But this is my personal experience with this.
I don't use TENS, but I think that is useful. In some cases, I suggest osteopathic treatment, and it works. It works.
И, наконец, последний вопрос. Xanım Saltıkovaya yenə də splint terapiyadan sonra dərhal daim
do you change the permanent constructions after the
No, of course, before orthodontic, no permanent reconstruction, only temporary, but kind of really hard material, and then after you finish, after you did second diagnostic event, then you can go to the permanent ones, of course, temporary.
Thank you very much.
Panel müzakirəsi bitdi. Hamınıza təşəkkür edirəm. Mən öz adımdan Rüfət doktora təşəkkür bildirmək istəyirəm panel müzakirəsində moderatorlarına görə və yenə də hamınızın adından bizim qonaqlara, bizim spikerlərə uzaq yol sərf edib, bura gəlib, bu konsepti burada yaymağa və bizim doğrudan da həkimlərimizin bu konseptdə olan məlumatını artırmağa sərf elədiyi çabalarına görə çox təşəkkür bildirmək istəyirəm və istəyirəm ki, hamınız alqışlayasınız. Eyni zamanda bu görüşün, bu yığıncağın ərsə gəlməsində çox böyük zəhməti keçmiş təşkilat komitəsinin üzvlərinə minnətdarlıq bildirmək istəyirəm. Bizim Hüseyin doktor, gözəl aparıcımız Hüseyin doktora, Rafael bəyə çox təşəkkürümü bildirmək istəyirəm. Bir dənə üzvümüz var, çox təəssüf ki, biraz nasazlayıb, dünən sistemlə amma bir gün vaxt tapıb 1 saatlıq saatlarımlıq gəldi. Anar Kərim doktora minnətdarlığımı bildirmək istəyirəm. İstəyirəm ki, onu buradan dəstəkləyəsi, tez sağlasın, tez ayaqları üstə dursun. Dəvətimizi, sözümüzü yerə salmayıb, bizim bu tədbirimizə gələn, iştirak edən bütün qonaqlara minnətdarlığımı bildirmək istəyirəm.
I would like to also say thanks to our interpreter because tərcüməçilərimizə çox böyük minnətdarlığımı bildirmək istəyirəm. Bir tərcüməçimiz biraz o da nasazdılar. Vüqar doktoru çox yaş tanıyırsınız. Özü çox istəyirdi üzrxahlıq eləsin ki, bir gün o tədbirdə tərcümə edə bilməyəcək. Təzyiqi dünən 160-ın üzə idi. Bir gün bir tər yoldaşından gəlib əhlindən tutarsa ki, gəlsin üzr diləsin. Bəlkə alındı, tərcümə eləsin, alınmadı. Amma onu çox gözəl tərcümə ilə Orxan bəy, qalxın zəhmət olmasa. İnanın ki, çox belə qəribə bir situasiyadaydıq. Tərcümə öz ki, çox vacib şeydir və sağ olsun Ziba xanım, sağ olsun Orxan bəy bizi çox çətin bir vəziyyətdən çox yüksək səviyyədə çıxartdılar. Orxan bəy, çox minnətdaram sizə. EFO adına öz həm təsisçilərimə minnətdarım bilmək istəyirəm ki, 3 ay, 3 months, day and night, biz bu tədbirə hazırlaşırdıq və inanıram ki, hər şey lazım olan səviyyədə oldu və bizim bu zəhmətimiz, bu çabalarımız boşundan keçmədi və siz bura gələndə özləntiləriniz heç olmasa müəyyən bir hissəsi özünü doğrultdu və doğrudan reallaşdı. Eyni zamanda da çox iş görən, amma demək olar ki, görsənməyən bir qrup insanlar var. Onlara da öz təşəkkür bildirmək istəyirəm. İstəyirəm onu da alqışlayasınız. Təxminə xanımın asistenti, mənim öz asistentim, EFO-nun ofis meneceri və EFO-nun işçisi Gülşən xanıma və sonunda last but not least mən doğrudan da biz birinci dəfə görüşəndə inanın ki, mən bu təklif eləyəndə mən inanırdım, mən görürdüm ki, doğrudan da hər şey çox gözəl olacaq və mən EFO adından, VieSID adından bütün bu konferansın ərsə gəlməyində təşkilatçı əsas main kompaniya kimi iştirak edən Azena Qrup kompaniya və şəxsən Günay xanıma təşəkkür bildirmək istəyirəm. Günay xanım, inanın ki, paliçka vuruşalçık, ana bulan naşı paliçka vuruşalçık 5 dəqiqəyə nə problem olsa həll olunurdu. İnanın ki, elə bir iş görülürdü ki, həmin iş üçün saatlarla vaxt sərf olunurdu və öz aramızda qalsın, bir sir kimi deyim ki, hətta mənə biraz şantaj deyirdi ki, doktor, biraz da tətikləsəz, biraz da mənə təzyiq eləsəz, mən sizi bloka salacağım və heç vaxt sizin telefonuna cavab verməyəcəm. Çox sağ olun. Qədərləriniz, gələn qədərləriniz həmişə sağ olsun. Hamınıza minnətdarımıza, hamınıza təşəkkürümüzü bildirdiyim. Görüşənə dək, dostlar. Vatara iyi olacaq indi.